I'm going to record several podcasts that walk the student through operative reports and how you would code one. We're going to be using the PCS worksheet that is on the content page as part of your additional resources, because really all you're doing when you're assigning a PCS code is answering specific questions, and each answer is what tells the student which character or which value in the PCS codebook is going to be used to build that PCS code. The report we're looking at today is an operative report where there are 4 procedures listed. You see them here. In some previous podcasts, I had highlighted things, and students have told me that it's difficult to see them sometimes. So what I'm going to do instead is to give it a different font color. Like, for example, I was highlighting procedures in green previously. Now I'm going to just change the font color. So I've identified 4 different procedures that I have to decide if I'm going to assign a PCS code or not. Every time I'm coding an operative report, I'm thinking about the questions that are in a PCS worksheet. Until you know as a coder what questions to ask, I suggest you use the worksheet so you can remember what exactly you're going to be looking for. You can see where I have inserted in this particular worksheet, there's 3 tables. You can insert as many as you think you might need, or you can insert them as you need them, however you're going to be using them. And then you're going to look at your questions. The first question you're always asking as a coder, what is the intent of the procedure? The intent of a procedure is what the surgeon's end goal is. And that is what helps you determine that root operation. The operative report may go on and on about whatever he or she is doing in the person's body. But what you're really reading for is what is he or she attempting to accomplish. This operative report we're doing today is a good example of how you answer that question. The first character is which section of the PCS codebook are we using, and in the first part of this semester you're only going to be using the medical and surgical section of the PCS codebook, so your first character is going to be 0. Your third character is your root operation, which is really important, and that is the main term if your coder is using the index. The reason why in the questions here we put the third character in front of the second character in answering our questions is because the root operation is the main term that the coder is using once you open the index. I do not always code from an index, although sometimes I do. I typically code just knowing what the root operation is, knowing what the body system is. I'm going to go to that table. But as you're learning to code, don't feel bad about using the index. Many coders use the index to get to the tables they want to find in the PCS codebook. The next question you're asking is, where in the body is this being done? Which body system and which body part? Sometimes it's not as evident as you might believe. This operative report we're looking at today is a good example of this. What is the approach? If the surgeon says he opened, or there was an incision made, or he talks about the length of an incision, then there's no question it's an open approach. But if a scope is used, or if the surgeon is going through a natural opening or an artificial opening on the patient's body, then you might want to use that approach decision tree. Once you know what table, you will be looking to see which device options are in that table and which qualifier options are in that table. You really can't answer those questions until you know which table to go to, and the table is determined by the first 3 characters. Okay, so now we've looked at our worksheet. Let me minimize that and let's go to our operative report. In a green font, I've put the 4 things that are listed as procedures by this surgeon. Some of them may be procedures we're going to code, some may not be, but we'll work through that as we go. The justification that's in this operative report is not usually present in an operative report. Sometimes it is, but I think in this situation it's used here for education to help the student or the coder know why something's happening. But as I said, typically I don't see justifications in operative reports. It's not a bad thing to have, but I don't count on them being there, I guess is what I'm saying. Then in the operative note, thinking of the questions that we've just read on our PCS worksheet, let's start to read that. The patient was taken to the operating suite, placed in the supine position. Supine position is lying flat on the back. A tourniquet was applied to the left upper extremity and set at 250 millimeters of mercury. The arm was prepped and draped in the usual sterile fashion. The area in the palm and the elbow were infiltrated with 2% lidocaine and 0.25% marcaine by me, as well as IV sedation. The arm was maximally elevated, exsanguinated, and the tourniquet was inflated to its preset pressures. That entire paragraph, what we really are looking at is this body part that's mentioned, the left upper extremity, that may or may not be what we're going to code, but it's definitely part of the body system. The next paragraph, the first aspect of the procedure was to go ahead and make an incision in the palm. Incision tells you it's an open approach. This was extended down to the transverse carpal ligament, which had reformed with scar tissue, and an open release of the carpal tunnel was done, both the palm and volar forearm through the limited incision. Open is again telling you which approach you're going to be coding. A synovectomy was also performed due to the heavy reactive synovial tissue encountered. We're going to determine if we're going to code a synovectomy or not. So what you're determining is a synovectomy included in this procedure that's normally done for the release of the carpal tunnel and the cubital tunnel. The synovial tissue was submitted to pathology. Even though it was submitted to pathology, it's not diagnostic unless the surgeon tells you it's diagnostic. Anything removed from the patient's body is typically sent to pathology for analysis. It does not mean it's going to get the 7th character X for diagnostic. The surgeon has to say so in the report that it was sent for diagnostic purposes. The area was irrigated with antibiotic solution, all bleeding meticulously controlled. After complete release of the carpal tunnel and the transverse carpal ligament release, the incision was closed using interrupted sutures. After complete release. Release is telling me that operative. Release is helping me know this is our root operation. Following this, my attention was directed at the elbow. The medial epicondyle region from the previous scar was incised carefully, removing thick, hard, scarred tissue. Two things I want to say here. When you are talking about incision, that again is your open approach. And anytime a surgeon is removing scar tissue, your root operation is almost always going to be release. Because what's happened is that scar tissue, let me just underline it, that scar tissue is constricting some body part, and that's why release has to be done. After a considerable amount of dissection, the ulnar nerve was identified and released. This is our first hint of what body part and body system we're actually looking at. Previously, it just said left upper extremity, but now we're learning that the release is really not the left upper extremity, but rather specific nerves. The ulnar nerve is identified and released. The nerve appeared hyperemic and compressed. A minor transposition of the nerve and partial submuscular was performed and the area irrigated with antibiotic solution. The wound was closed using adjacent tissue closure, using 5-0 Vicryl for the deep subcutaneous tissue layer and 4 nylon closure for the skin. Now, the physician mentioned in his procedures performed, he talked about adjacent tissue closure. So what we're going to determine is that actually a procedure, or is that just something that's done as a normal course of a procedure? Reading down, the patient had incision lines dressed with a xeriform This is cage. This is supposed to be gauze. This is a typo in your operative report. Xeriform gauze, fluff, and 4-inch cling. Patient had the hand maximally elevated in a stockinette sling. The patient tolerated the procedure well, and all sponge counts, needle counts, and instrument counts were correct post-operatively. The patient is aware of possible post-surgical sequelae, post-traumatic complications, including but not limited to hypertrophic scar, wound dehiscence, wound infection, retracted scar, contracted scar, nerve compression, nerve injury, tendon injury, further wasting and numbness of the hand, and the possible need for further revisional surgery and or occupational therapy. Nothing in this paragraph helps us to code the PCS code. It's just part of an operative report that the surgeon typically dictates, and that's it. So identified several things in moving through here. The one thing that isn't exactly talked about, it mentions here about the transverse carpal ligament, release of the carpal tunnel, but what I wanted to say here, release is going to be the operative report, but it's what you're releasing. If you don't know this, when you are releasing for a carpal tunnel syndrome, what you're actually releasing is the median nerve. If you don't know that, you can Google it and find out that median nerve is really your body part here. And when you are releasing a cubital tunnel, it is your ulnar nerve. The best way to think of this is to go to Google whenever you don't know what body part is being released. The full definition of release as your root operation is the body part being freed is what you're going to use as your body part, not what you're cutting to free the body part. You're coding what body part is being freed once you've cut that scar tissue. Again, if you don't know what is released, you go to Google and you just Google carpal tunnel release and you read a paragraph or two and you can see the median nerve is what is released. Let's just code those two before we go any further. So go back to our worksheet. And let's answer the questions for the carpal tunnel. First, this is your intent. Release the median nerve. I'm going to put that in purple so it stands out. Which section we've already talked about is going to be the med-surg section. What is the root operation? We've talked about that. Is release. Where in the body is this procedure being done? We mentioned earlier the body part we're talking about is the median nerve. So which body system is the median nerve in? Next question you're going to ask. The only two body systems that involve nerves in your PCS codebook are the central nervous system and the peripheral nervous system. If you don't know which is which, what you can do is go to your PCS codebook. In your codebook, you can look at your central nervous system. And on the first page of every table, it has all the options in this body system. So when we read down for the body parts, you just read down this column. Median nerve is not there. So now let's look at the peripheral nervous system. That first page again, and read down, and here's your median nerve, just above it your ulnar nerve. So both releases that are accomplished in this procedure, this operative report, are in the peripheral nervous system, which is a value of 1. So the body system is peripheral nervous system, which I abbreviate as PNS, peripheral nervous system. Now we know our root operation is release, and it's a peripheral nervous system. So if we look at that table, you see the second character is 1 for the peripheral nervous system. And if you look over the far left, character 3, release, the value is N as in Nancy. Word operation is N as in Nancy. Peripheral nervous system is 1. And what is the value for the median nerve? Look back on here. Look back on here, the median nerve, the value is 5. Okay, the approach is open. The surgeon talked about making an incision. And we look at our table again. And open, the value is 0. Now, is there a device? Is there a qualifier? The only way to answer that is to look at that table. So which table are we looking at? The table we're looking at is the first 3 characters, which we already determined is 0, 1, N. So we go into our code book and we find, so we go to our 0, 1, N table. We've determined the median nerve is our body part, that's 5, and it's an open approach. And you see there are no options but Z for the device and the qualifier. If we had gone to the bottom of the page and saw something that said continued, then you know that this table is continued on the next page, and there may be options in the device and qualifier columns on the second page. You have to always look at that continued sign. So we have none, which is a Z. And I know this is taking extra time to do this on this one, so I won't always do it, but I want you to be able to walk through it once and understand what you're doing. So really, now you have your 7 characters for the release of the carpal tunnel syndrome. So going back up to our table here, just to be sure we understand it. Peripheral nervous system is the body system, value 1. Peripheral nervous system is our body system, 1 is the value. Root operation is release. Your body part is the median nerve, which is 5. Your approach is open, which is 0. No device, no qualifier. So now you've got your first PCS code, the carpal tunnel release. Think back to the second procedure we talked about was a cubital tunnel release, which we know is the ulnar nerve. Reading through the operative report, again, the only difference in the 2 procedures for the cubital tunnel syndrome and the carpal tunnel syndrome are that in the first one, carpal tunnel, you're releasing the median nerve, and in the cubital tunnel, you're releasing the ulnar nerve. We've already talked about how we located those body parts. No device, no qualifier. So now we've coded 2 things. Let's look back at our operative report. We've coded these 2 things, the carpal tunnel release and the cubital tunnel release. We have not coded the adjacent tissue closure and the flexor synovectomy. Anytime we're talking about closure, unless it's a lot bigger procedure than what's being described here, we remember that there is a guideline that talks about procedural steps necessary. So what I'm going to do is paste it here. Guideline B3.1b, procedural steps necessary to reach the operative site and close the operative site are not coded separately. So unless he's given me a lot more information than what's given in this report, I would just use that guideline. I would not code this adjacent tissue closure because I think he's not talking about a graft, he's not talking about tissue transfer where the nervous system supply and the blood supply are left intact. He's just talking about closing tissue over this area. So I would look at that guideline, and from that guideline, I would not code the tissue closure. Then we get to the flexor synovectomy. What I suggest doing with this one is that you would actually look it up in Google, just read about what a flexor synovectomy means. Synovium is the fluid that lines a joint. If you think of that, I'll put this in here. Synovectomy is removal of synovium, that lines a joint. So now when you think about removing synovium, we're going to answer more questions that have to do with that procedure, because that is another way of looking at something very differently. So now let's work through answering these questions about a flexor synovectomy. What is the intent of the procedure? The intent of the procedure is to remove some of that synovium. And you may be thinking, okay, removal must be the root operation. It isn't. Removal is a root operation. If you read the full definition, removal is a root operation for devices. We're not talking about devices here. We're talking about body parts. So if you're removing a part of a body part, what is your root operation? It's excision. If you were removing the entire body part, it would be resection. But since we're only removing part of a body part, it's excision. Then if you think, what is the body part? Synovium is not listed in the PCS as a unique body part. You have to think of synovium as part of a joint because it lines the joint. So if we read back through our operative report, you find that the joint we're talking about, read back through our operative report, the joint we're talking about for the synovectomy it's the carpal joint where that synovectomy was performed. So now we're looking at a carpal joint. So if a carpal joint is our body part, what's our body system? Well, it's going to be upper joints, right? So if we go to the code book, and what I've done here, I wanted you to see before I change anything, I keep notes throughout my code book to help me remember so many things. And then I use just a sticky, so if I want to see what's under them, I can just move them to somewhere else on that page. And that way I don't lose everything and I can still see. Okay? So, looking at the upper joints, it's R. The root operation we're looking at is excision, which is B. The body part we're looking at is the left carpal joint, which is R. The approach is open. And then we have all these devices. But in the case of this procedure, none of these apply. There's no devices that are placed or left in during the procedure. So it's no device. And looking at our qualifier, again, none of these apply to a synovectomy. So our qualifier is Z. Go back to our worksheet. Excision's our root operation. The body part is the carpal joint. So the body system then is the upper joints. The only joint body systems we have are upper and lower. Obviously your arms are in your upper joints. Upper joints body system, R is your value, and that carpal joint is R for left. Don't forget your laterality. The approach is open. And as we mentioned earlier, no device. No qualifier. Okay. To review our body system, which is an R. Root operation is excision. B. Body part, the carpal joint, and R. Approach is open. No device. No qualifier. So now we have 3 procedures that have PCS codes that would describe what's happening in this operative report. I know this has been probably painfully slow for some of you, but for others, maybe it was really important that you see the steps you go through as you read an operative report. If you have any questions, please post them in the discussion board. I'll be happy to answer them there. Thank you so much. Have a good day.